All right, good morning, everybody. Welcome to another installment of Grand Rounds. This morning, our speaker is Dr. Dan Gralnek. Dr. Gralnek trained at the University of Arizona for most of his medical training at medical school and residency, and was in private practice before joining our group here at UW in 2014. He's an associate professor in our department and is the director of the HoLEP program, also has clinical interest in the gender program here at UW as well. And with that being said, I'll turn the floor over to Dr. Gralnek to talk to us about surgical modalities and BPH. Dr. Dan.
Hope everybody can hear me. Thank you, Dan, for that. That was pleasant. So I'm Dan Gralnek, in case you don't know me, and I'm here to talk about surgical treatments or different options for BPH. We'll get into a number of them today, and so just a quick, these are my disclosures. Objectives, hopefully today we'll talk about a number of different treatment options for BPH, especially a bunch of new ones that have been coming out recently, look at the overall drive to minimally invasive treatments, and then at least briefly discuss kind of the over-reliance on medications. So BPH, I don't know if any of you have ever heard of it, but it is the main treatment or main thing that causes visits to a urologist in the clinic. Prevalence is very high. 35% of men, at least in the US at age 50, are having symptoms or treatment, and 90% at age 85. Worldwide, it's probably actually a little lower, but overall annual treatment and evaluation for BPH exceeds almost $80 billion. 40% of that cost is based on pharmaceuticals. And then half of men with symptomatic BPH have treatment, much higher percentage in the United States than other places around the world. The other thing is that there's been a drive recently to different treatments for BPH, and they've increased 23% in the last 15 years in terms of people looking for the other options. So therapeutic options, certainly there's some basic ones. We talk about behavioral, such as dietary modifications. You'll talk to people that will decrease how much they drink at night, different foods they may avoid, certainly irritants or things that cause constipation. Exercise programs, including pelvic floor physical therapy, have been shown to help with BPH as well. And then, of course, there's the pharmacologic or nutraceutical options such as supplements, beta-sitosterol and saw palmetto certainly are well known. Alpha blockers, 5-alpha reductase inhibitors, and anticholinergics are all medical therapies. But really, one of the things that we're here to talk about is procedural options. And I've broken them down into three different sort of categories, sort of historic, and then I've called it the transition time when there are medications and some of the other options, and then there's newer ones. Just to give you an idea of kind of the timeline of treatments, you know, the resectoscope was first invented back in 1926, and then there were a number of improvements slowly over time with that. 1945, the simple prostatectomy was described. And then TURP became popular around that time. I do have some stars on the timeline. I don't know that we'll have time to get into that discussion, but we might. Then in 1978, the first alpha blockers arrived. And then, so in 92, 5-alpha reductase inhibitors and laser for BPH was started at that point. HoLEP came around in 98. PVP in 2001. And then the robot simple prostatectomy was described in 2007. But if you start to look at this timeline, I mean, if you look from 1926 until 1978, the only treatment available was either a TURP or open simple prostatectomy for the most part, and then medications came around. In the last 15 years, there's been a number of different treatment options. PA and Resume, prostatic lift or Urolift, and ThuFlep. We'll get into what that means. And then things falling from the sky, iTind, aquablation, and then Optilume. So let's briefly get into the historical treatment options. So back in 1867, Dr. Bill Roth described a perineal approach to a partial prostatectomy, and that was for BPH as well as cancer at that point. And then, in 1904, the radical perineal came out with Hugh Hampton Young and Halsted. At that point, one of the other treatments was just open cystotomy for urinary retention. And in the 1920s and 30s, it had an almost 30% mortality rate just from that procedure itself. So getting into a little bit more about the open simple, Dr. Millen in 1945 sort of described this. And actually, one of the interesting things was that the Millen prostatectomy came about because he was actually interested in TURP, but World War II had broken out, and the electrical current blade that they used, which was made out of tungsten, all the tungsten was being taken by the military, and so he wasn't able to have anything, so he came up with the open simple at that time. It was a very good surgery. It was quick, it was bloody, it was highly effective, and most importantly, it was my favorite surgery. Average blood loss, a number of different treatments or a number of different studies have looked at this, and certainly at times it could be very bloody. The average blood loss could range anywhere from 350 to 2,300 cc's. Then they came out with endoscopic treatments. So in the 1910s and 20s, they came out with a hollow punch, which was similar to sort of dermatologic biopsy. There's a circular knife that they can use, and they would pass this catheter that had a sharp edge on it, and they would punch out pieces of the prostate just by tactile feel. However, a number of people died from that. And then in 1926, Dr. Stern described the first TURP, and that was the beginning of the resectoscope. At that time, he described it as a simple cystoscopic surgery, and when other people tried, they found they had a lot of problems getting the electrical current to work and other things like that. Eventually, it got improved in 1931 by Dr. Davis with a brand new resectoscope. And one of my favorite quotes, almost overnight, men everywhere bought their machines and started whittling. So TURP had a significant mortality associated with it, almost 5%. And there were several interesting things, such as a couple of patients that died from a massive intravesical explosion and then bled out intraperitoneally. And then they finally figured out some of the side effects, including the TUR syndrome, which limited time for how long you could resect. And this was really a absorptive problem with bradycardia, hypertension, anemia, and death. This was described by Nesbitt, who was the chief at Michigan, where Dr. Nakata recently spoke at the namesake meeting, and Dr. Glickman, who was a resident with Dr. Nesbitt, who took over at Mount Sinai Hospital in New York City, where he became one of the biggest practitioners of TURP in the world. And much more importantly, he then moved to Tucson in 1984, where he worked at the VA, and he would sit in the back corner and yell at me while I learned how to do a TURP and refused to let me use a camera. Originally, when patients had TURPs, they were in the hospital for 1 to 2 weeks. They were on CBI. The bottles at that point were glass, and they'd be walking around with glass bottles hanging. They were usually in the hospital, like I said, for anywhere from 1 to 2 weeks. That dropped down into the 3 to 5 day range in the 80s. And then eventually, when CMS refused to pay for more than 24 to 48 hours, the national average dropped at that point remarkably. They did have some studies. Dr. Carnival did a volume study of how much tissue was resected on an average TURP, and he looked at 10,000 different specimens and found overall there was about a 26% reduction in overall prostate size from a TURP. So then moving on to sort of what I'm considering the middle era, or when medications came out, a number of different treatments were available at that point, and we will get into these. So we started with microwave back in 1991. Dr. Lee in Singapore came up with it. It was a catheter that had a 2.5 to 3.5 centimeter long treatment probe, had a balloon at the end that would hold it in place. You would measure the prostatic urethra, and while it was in, the microwave would turn on, and it would run for about 10 to 15 minutes, and temperatures would reach about 70 degrees. Afterwards, the catheter would be in for at least a week, and if people had short prostates, it could fry the entire sphincter at that point. But it was really one of the first things that could be done while patients were on blood thinners, and it could be done in the clinic with minimal sedation. Then they came up with one of the first uses of a laser. So interstitial laser coagulation of the prostate. This was an 8 French tip. So a pretty good sized tip that you would plunge deeply into the prostate itself while patients were awake. And then it would start to coagulate and heat up the interstitium. Again, the temperatures were 70 to 80 degrees Celsius, really sort of destroying a lot of the tissue. And then there would be necrosis, and it would shrink after several weeks. There were less irritative symptoms with ILC than with a lot of other things, because really the treatment was much deeper and there was no mucosal treatment. It was also somewhat effective in getting rid of catheters for people, but obviously 40% of people within 3 years needed some other treatment. Then we came up with Uroloom, came out of China. It was based on the same concept as a cardiac stent, and was a bare metal stent. It was placed cystoscopically. It was a short and easy procedure, and it could be used for urethral strictures, for DSD, as well as for BPH. There was some concern that if part of the metal was sticking out into the lumen, that you could have problems with stone formation, and so they tried to avoid that. Patients did have some symptoms. They could sense the stent being there, especially if it was in the perineal region from urethral strictures. But so just getting into this, it makes me want to talk briefly about something else. So the Choluteca Bridge. So this is in Honduras. This is one of the main bridges that would get you from the capital to any of the towns outside of the coastal area of Honduras. So it was really the main line for people to get from one place to another. And it crossed one of the rivers, but they had a lot of problems with hurricane wind destroying bridges. And so they finally decided to redo it. And over a 10-year period, they found a number of people around the world to put up a blueprint to make one of the strongest bridges in history. So they put up this bridge. It finally got built in 1996. 2 years later, one of the strongest hurricanes in Central American history hit, called Mitch, and the bridge itself was completely undamaged. However, the river was rerouted. And so it ended up that the bridge did nothing. It actually didn't cross the river at all at that point. And so sometimes the best laid plans don't really take you very far. And so that was the Choluteca Bridge. And that sort of reminds me of Uroloom. Uroloom was a great idea that had a lot of problems. So it really became the poster child of complications. One study suggested less than 20% were still in place after 12 years. Different things that were required to remove them. Sometimes you could push the stent itself into the bladder and then pull it out either in one piece, or as it was invented, you could break out each of the individual metal strands and pull those out. This was a lot of work. Some people would open the bladder to remove them. 21, in one study, 21 people required loop resection of the epithelial tissue that overgrew it, and then they were able to extract it either with forceps. There was a couple of people that ended up having cystectomies. In the BPH and, in the DSD and urethral stricture usage, there were people who had new urethroplasties. It was problematic. So then moving on, they came out with TUNA, which was transurethral needle ablation of the prostate. And so this came out in 1993. The number of treatments were determined by the length of the prostate, and basically they would treat about every 10 grams with one treatment. It was short. You could go in with a cystoscope, you would extend these needles, they would go into the prostate and cause ablation of the tissue over time. It was very popular in the 90s, but it had an overall lower success rate and people stopped using it. It's still used somewhat extensively in China. Then came bipolar TURP, that came out in 2001. It had a big difference in that you could use saline instead of glycine or water, and so vision was better. The button increased tissue contact by 35% and was more hemostatic than anything else we had used. It had a lower TUR syndrome, less clot retention in a head-to-head study. And so this was relatively popular, and at some point you could do this procedure on blood thinners as well. So then green light, or photo selective vaporization of the prostate, came out. This was a potassium laser. It had different wattage. When it first started, they had an 80-watt laser. They're currently up to 180 watts. And it was really one of the first outpatient TURP procedures that could be done. There was actual removal of tissue instead of counting on necrosis to make a difference. They started using a diode laser in a very similar fashion for this. This was quite popular and at times still is. It had a short catheterization period postoperatively. The energy of the bladder neck probably brought on a lot of symptomatic dysuria. A number of studies have shown a somewhat high retreatment rate and bladder neck contracture rate. The diode laser, which was probably used in most places instead of the green light because of proprietary reasons, actually has a very deep depth of penetration, significantly different than most of the other lasers we use. And so the diode laser, which was probably used more in this country than any other, had even more symptoms and bladder neck contracture problems. Twice as high reoperation rate as TURP at 5 years and worsening over time on meta-analysis. So the learning curve originally was thought to be very short, but follow-up has shown that learning PVP is probably more difficult than expected. And then I won't quote myself. Then transitional options, there was something called a HoLEP, I've heard of. And this was invented in 1998 by Pete Gilling. And it really was an evolution from the interstitial laser. And then he started using it as an ablative technique, and then eventually moving on to enucleation. The problem with HoLEP is that it's had a small group of adherents for a number of years. And so it didn't really gain the popularity it may have deserved for the first 15 years or more. So one of the things I like about HoLEP is that it's size independent, but I'm not going to get into that much. One of the pictures there on the bottom left was I think it was a 140-gram prostate that had some cancer, and we did an MRI afterwards, and they measured the prostate at 4 cc's. So other options include the HoLEP, or the thulium laser, which is slightly different than the holmium in that it has a different wave. So instead of being pulsatile, it's a continuous wave, and it has less penetration than HoLEP, which isn't deep to start with, but it can cause a little more charring. Some people have suggested maybe it has an easier learning curve because hemostasis is better. But true thulium lasers have not been around a lot, and instead we'll talk about thuflep in a little bit. So once we get into the kind of newer treatment options, number of them here, especially the ones with the star that are considered MIST, or minimally invasive therapies. We'll talk about some of those as I think they're important. So the newer options. This lists Dr. McVary as the inventor, but that is not true. Sorry. So Resume is a endoscopic evaluation and treatment. It has a probe that is about 6 French that goes into the prostate itself. It's only in for a few seconds. It gives off steam injection under minimal sedation. Anywhere from 3 to 20 injections can be used. Recent evidence has suggested that the less injections you do, the better it may be. It had a 4.4% retreatment rate at 1 year, a lot of dysuria with it, and it did well for symptoms, but not necessarily for urinary retention early on. Moving on to some of the newer options, again, the UroLift. So this was a nitinol capsular tab attached to a polypropylene suture and a stainless steel urethral tab. And so the capsular tab would be fired through the prostate, and then as they placed the urethral tab, they could then compress the tissue over the suture and cut it. And so this was just compression of the prostate tissue. It really worked anteriorly rather than where most TURP specimens were done, more in the lower portion of the prostate. The retreatment rate is 8.5% at 2 years. Minimal anesthetic is needed, and this can be done in the clinic if you have appropriate mild sedation. Moving on to the Optilume. So this is a double balloon that's placed. It came out in 21, one of the more recent treatments. It was a combination device and drug. So the balloon is inflated, and it causes an anterior commissurotomy. And then it's really inflated up to 90 French. And that's left in place for 10 minutes. And the balloon is coated with paclitaxel, which was then get into the prostatic stroma and prevent closure. 23% retreatment at 3 years with that one. So again, 90 French balloon inflated in the clinic. Hard to imagine that that's particularly comfortable, but we haven't started it yet, at least for BPH. It's also used for urethral strictures with a pretty good success rate, is my understanding. So newer options, again, going on to the robotic simple prostatectomy. It was first described, sorry, I lost that one. 2007 in Venezuela. Single port then came out in 2020. And it has a lot of popularity as people have gotten used to using the robot and feel pretty comfortable with it. It's excellent in a number of different areas. If you have a large stone burden, it may be able to speed things up. If there's a diverticulum at the same time that needs to be treated, it may be very useful. And then the thought was that in a massive prostate that maybe HoLEP or other options weren't as good for. In theory, it's good. However, when I talk to people at the Cleveland Clinic, they've never really done any massive prostates. And they're kind of one of the leaders at this point. They claim that the largest one that they've ever done, and this was not a single port, they had to use multi-port for the size, was 400 cc's. There's a lot of mixed data in the outcomes when it's put up head-to-head against HoLEP, including claims of shorter hospitalization with robot versus, there's a number of studies out of Europe that say that people go home much faster with a robot than with HoLEP. Equal incontinence rates are one of the other arguments. Moving on to other treatment options, PAE. They're starting to describe PAE strictly for BPH. It was originally described in 2002 as a treatment for massive bleeding after a TURP. It also had been used after a post-biopsy hemorrhage. They then used it in 2009 for BPH itself. It seems to be a somewhat difficult procedure as you have to find relatively small arteries. They've tried unilateral treatment with not much success. And then bilateral, again, you've got to find these arteries on both sides. It was initially reserved just for very large prostates and patients that were unsuitable for other therapies. Likely the best outcome was for somewhat large prostates, but if they have a large median lobe, problems could occur. Sometimes the median lobe would necrose, and then they'd bleed from there, and the median lobe would be floating around in the bladder and have to be retrieved. 28% retreatment rate at 2 years for PAE, and at 1 year they found somewhere between 15 and 25% reduction in the size of the prostate itself. So updated guidelines came out this summer saying that PAE can be offered. Prior to that time, it was considered experimental. So you will see it advertised a number of places for BPH directly to primary care and patients. There are concerns. Sorry. Still on? Just checking. One of the concerns with PAE is sort of the amount of radiation that can be exposed. The procedure itself usually takes about 2 hours with fluoroscopy up to about 50 minutes on average. The doses of radiation can range from 150 to 750 gray or millisieverts, and that's similar to 50 to 75 CT scans. De novo retention occurred in about 5 to 8% of patients. That would usually resolve on its own. Again, the median lobe can be problematic. And then non-embolization sites or non-target embolization sites could lead to some other problems. The amount of radiation was estimated that they may have an association with cancer death associated with it at 0.117%, usually leukemias. In addition, different than most embolizations that people in IR do, They have a way to do this that actually they call the perfected technique, where they embolize proximally rather than distally first. And that's supposed to decrease the chance of sending the embolization into some of the other non-target areas. Other treatment options include aquablation, again by Dr. Gilling. This came out in 2013. This is a robotic water jet that is placed at the same time that you have a transrectal ultrasound to watch. Ended up having a 4.3% retreatment rate at just 2 years. There was 31% reduction in the size of the prostate itself at 6 months. Has a somewhat short learning curve, estimated at 5 to 15 cases. So it's a computer modeled. It spares the anterior 120 degrees of the prostate. Each pass could go up to 2.4 centimeters in depth, but it could be done repeatedly. And so a number of proponents will say that you can do prostates of 500 or 600 grams because you just run it over and over and over. The bleeding can be significant. It requires cauterization, usually with a bipolar loop at the bladder neck, and further resection sometimes is required at that point. One of the big advantages is that it does not lead to much problems with erections or ejaculation. It does require an overnight stay, catheters anywhere from 1 to 5 days. There's no pathology, and at least 6% of the time they have a rising PSA within 12 months. That gets us to the iTind, or some of the temporary implanted devices. So this was taking the Uroloom concept, but trying to prevent the permanent placement, and then nitinol instead of steel. So they have, since it was invented in 2011, there have been several different companies that have come up with options. So there's the iTind, the X-Flow, the ZenFlow, the Butterfly. These are all FDA approved, and we'll see a lot of this at some point. It can be placed in the clinic, which is one of the big advantages. Some places are putting it in place in the operating room. Compared to sham procedure, where they just looked in and put a balloon in temporarily, it had a 78% improvement in IPSS at 3 months versus the sham, which had 60. Again, no change in erections or ejaculation with these devices. So the X-Flow, in fact, during this talk, it's already changed its name now to the Eurocross because it got bought by another company. And so you can see that it's basically put in and expands itself during that time. The ZenFlow and the Butterfly are actually permanent, but easily removed. I don't know, I've never done one, so. But so here are some pictures of them in place. So the iTind itself is implanted through a cystoscope, folded up. This is basically like a basket, a 3-wire basket that's placed in the prostate. It's then left in place for 5 to 7 days, during which it slowly expands, and then it is removed. And you can see how good it looks. So patient number 1 over here, you can see before implantation versus after, looks pretty good. Patient number 2, you can see that the 3 wires sort of make channels at 12, 5, and 7. And at 3 months after, on the far side, you can still see that there's a channel there. Some of the recent studies have actually shown that the iTind has the best improvement in IPSS of all treatment options. So another option is ThuFlep. So this is thulium fiber laser enucleation. Came out in 2018. It's very similar to HoLEP and HoLEP, but it's a different laser itself. It's quieter, has a smaller box. It's probably cheaper in some places around the country. Let me change that to around the world, not in this country. Basically, the holmium or the thulium laser works with YAG crystals, and then it comes out of the laser. The thulium fiber laser is different in that it's a diode laser that goes through a rod inside the machine itself through a thulium doped fiber. And so it picks up, instead of getting it from the energy source itself, it picks up the thulium in the fiber itself. I don't know why that's a different, but you'll have to. So HoLEP itself, it causes a lot more charring effect on tissue, and so that leads to better hemostasis, which may be why it's very popular. To date, there's no significant difference seen in any clinical outcome between these laser treatments. So in the end, so what? So there's a lot of different treatment options. I mean, if we go back and look from 1926 to 1991, you know, there was TERP, open simple, or the new medications. And so if you ask a patient, you know, do you want surgery or a pill, only 5% of them will choose the surgery unless they're in retention. Medication use is significant. It's at least 40% of the cost. But the difference is that it's not a pill. It's a pill every day for the rest of your life. And so I think that while it's easy to use medication, it is certainly overused at this point. Long-term medication has at least 35% dropout rate. Alpha blocker usage for more than 2 years in men over 65 increased dementia risk, and 5 ARIs were similar in that standpoint. Medication doesn't make a huge difference. The average IPSS improvement is only 4 to 6 points with alpha blockers, and with combination therapy, you can get up to about 7 or 8 points. And the MTOP studies show that just using placebo, 3.6% of people would have worsening in their LUTs of 4 points or more within 6 months. And you could decrease that with alpha blockers, but it would only decrease from 3.6 to 1.9%. And so MTOPS, which is used as one of the main reasons that you should be on medication, really does not make a massive difference. One of the real areas that medication may be useful is in people in acute urinary retention. If you start somebody on a selective alpha blocker, they're twice as likely to pass avoiding trial. However, people would just then stay on the alpha blocker, even though long-term that may lead to other problems. Alpha blocker use definitely has some change in ejaculation and 35% anejaculation rate. So the other thing is that the time gap between medical therapy and surgical therapy indicates that if we wait long enough, surgery doesn't work as well. For patients who are on medications for more than 3 months, they got less improvement with surgery. If you had an IPSS that was moderate rather than severe, you did better after surgery. But if we wait until people are severe with their symptoms, there's some significant problems with incontinence and overall storage symptoms. They're far exceeded. So overall, I think that medications are overused. They're used too long. They're making bladder function decrease over time, leading to poorer outcomes for surgery. And it's reasonable to use medications for short term, but I think that with the new MIST treatment options that are minimally invasive, that may be a much better option for people rather than waiting as we have been doing. So overall, I think there's a lot of options now for LUTs with less invasive therapies. Outcomes are good across the board, different side effect profile and longevity of those treatments that we need to learn a little bit more about and let patients know about. But that earlier intervention may significantly improve patient outcomes. And so I think that's really what we need to look into at this point.
Right.
Thanks, Dan. Really great review. I enjoyed the historical perspective. So a little bit of a leading question, but why do you think there's so many treatments for BPH?
Well, first of all, it's a massive market. So there's a huge amount of money that can be made, so people are interested in it. It has a high incidence of, high prevalence of problems, so there's a lot of patients interested in treatment. And if we had a really good treatment, there'd be one. But there isn't one answer for all of these problems. And so you'll get people that are, interested in preserving erections and ejaculation, and they really want some of these minimally invasive treatments. And that's why people have gotten away from TURP and open simples. And so I think that as we go on, there's going to be more and more treatments that are much more focused to avoid some of the side effects more than anything else.
Yeah, I agree. If you look at the history, TU, MT, and tuna, as well as tamsulosin, was first trialed here during Reg Bruskowitz's tenure as one of our faculty, and he also championed TUIP, which still might be a very good treatment, but basically didn't require any additional technology. But to put in a plug for AUA, the AUA has a technology forum now where younger or any urologist can go and learn a little bit about new ideas, starting your own company, and so on. And I attended last year, and the person who did Urolift gave a very good presentation about how he took sort of an idea on a napkin to something that's being used, a fair bit worldwide. So certainly for those at AUA, this technology forum's very good.
Right. Kyle? Wow. I think that's a great question. And I think that as more and more options are coming out, we need to be exposed to them and try and get an overall picture of what's going on. Certainly financially, there's a push for certain things. Like aquablation will pay, I think, 30% bonus over everything else until the end of this year. And so there's been a big push financially for that. But I think overall, you have to look at what are the retreatment rates and can it be something that can be done in the clinic? I think these real clinic-based missed options, if I have to take someone to the operating room, suddenly we're talking about a different procedure, a different cost, and other things like that. If it can be done in the clinic, I think that you can easily compare this to medication. And I think medication is completely overused, and we need to get away from it. And I think that if you told somebody that they can have a 5-minute treatment in the clinic, which doesn't cost them a lot of extra money, with some mild, sedation. I know that we've discussed nitrous use in the clinic and other things like that. That has a significant improvement over medication. Those are probably the thing. But I think that the fact that there are so many different treatment options tell us that we haven't hit on the exact right answer. Chris?
Really what resonates with the thought there is that narrative around too often I've seen patients who are on alpha blockers and they put on them for just the refill for a month. Say you have a patient that's like medicated. How would you counsel them about medication and what to expect and how soon it would work? Specifically, the alpha blockers, what's your.
So when someone comes in, certainly I would tell them that medication is an option. It may make some mild difference and it'll make it quickly. Most of the time alpha blockers are going to work within a couple of days. You may get to maximal therapy benefit at 4 weeks, but they'll usually see a difference by a week if they're going to. And then what I usually tell them is, this medication is great for a while, but do you really want to take this for the rest of your life? And improvement may plateau and you may not continue to get better. And as the prostate grows or the bladder changes over time, this medication may not work as well. And so see the improvement that you can get after 3 months or so, and then let's talk about other options. Because I think long-term they may, if you have a single treatment that will take care of you for the next 40 years, they may really prefer that. Or they may say, it's not that bad, but if you have something like, an Optilume and you can just shove in a 90 French catheter for 10 minutes and that'll make the difference for 5 years, I'll take that.
Or just start setting people up with I can
60%.
Time for one more? Can I ask a question? Okay. My question is this, kind of piggybacking on what Dr. Nakata said, is with the growing array, of procedures, how do you think we best select, patients for them? And specifically, with the question of kind of when, if/when we should intervene surgically, right? So like patients who come see us, they're symptomatic, question is this someone you're going to help by intervening with surgery earlier, and kind of keep them out of retention and bladder decompensation and all that? How do you see the future, there? And like, what are your thoughts on that in terms of, what tools we might use in the future, how we might decide? That's the question. The quick observation is, I might make is Optilume, we don't really know why it works at all in strictures or BPH, but it seems to. And that might suggest to me that there's potentially a common pathogenesis in both diseases. So there's just a provocative observation. Anyway, what do you think?
I think that's the hardest question I've ever been asked in my life, and I will just end it here. No, I don't know the answer to that. I think that's a fascinating question, and the question is, does any urodynamics help in figuring this out? And maybe in the end, it'll be something that we need to do more of. I think that primarily, currently, since this is something that we use as a treatment for bother more than anything else, that's how we're going to determine things. And so I think that we'll probably get into more minimally invasive treatments sooner, and then more things will develop after that. But I don't know the answer to that on what. We don't know how to figure out who's going to be the one that gets worse currently.
Real quick though, the concept of the comment I made about the sham iTind and the remarkable improvement of IPSS when they didn't do anything, you have to take a step back, because so many of these minimally invasive procedures that are proving their efficacy with a before and after IPSS, is that what patients see as the most meaningful outcome on the other side? This is what we have held ourselves to as we assess these as the instrument. And is there a better instrument that focuses on what the patient is trying to achieve? I think that's an opportunity for improvement.
Yeah, I would say, first of all, IPSS, it's questionable, because it's a form. And I think if you were to really truly want to assess these treatments, you'd use, flow studies, right? Flow rate is ultimately the best test, which is what Reg used to always say. Now, I think there's a case. I mean, I'm a QOL guy, so those are forms. So, it's hard to know. But the one thing I know is, as you become a true expert, the tendency is to do less. That's a clear observation of all experts in their given fields. And some of that is obviously a history of trial and error. But I think that's an important truth here. So I think what happens is when you come up with this new treatment and you see all these patients getting the treatment, that's not necessarily the sign of expertise, right?
Thanks, Dan. I do have one question about education.
Yeah.
So we've got a lot of young, super smart physician, budding urologists in the room. And Ali, yes. Maybe is budded, not sure yet. But so with this kind of smorgasbord, if you will, of options for learning how to take care of patients with symptomatic BPH, what do you envision as ways to teach our trainees, the different options, and there are different platforms for teaching, webinars, hands-on courses, taking care of patients in the training program. Just one historical vignette is, I joined the department in 2006, and 2 years later, I was sitting in a hotel room or a hotel conference room in Chicago, learning about this thing called the green light. And a few weeks later, I was doing it to a patient. Was that the right approach? Don't know, but that was one approach, and those types of learning opportunities are still out there. What do you envision as an optimal way to teach trainees about all these different options?
Well, there's so many of them that I think that simulation is a reasonable way to at least have exposure to it. But I think that has some minimal plateau at which it's not that useful. Seeing it in the real world makes all the difference. I think that we need to expose people to the different treatment options, and then we need to follow up and see what the outcome is, not just the procedure itself, but how do they really do from the patient perspective as well as objectively, like flow studies and other things like that, to see how long does something work, how much better do people actually get. I think simulation gives you an idea of things, but then we need to be exposed to them. And so we need to do a better job in making sure that we have other treatments. We can't be a one-trick pony. No matter how much I like HoLEP, we need to have other options, and we need to do it quick.
Any further questions or comments for Dr. Gralnek? All right. Thank you very much, Dan, for that presentation. And we'll take a few-minute break and switch over to Unknown Conference. Thank you, Dan.